Good morning everybody. Today I'll be speaking on manual small incision cataract surgery in hard cataracts. So some of the facts you have to know on when you're managing a hard cataract. So the hardness of any cataract is directly proportional to its brown discoloration. The older lens fibers in the center of the lens, they become dehydrated and compacted, and also cross-linking of the soluble and insoluble proteins increases its optical density and decreases the transparency, and this causes the lens to be susceptible to oxidative damage, leading to progressive color changes in the lens. So why is there always a fear when performing a cataract surgery in hard cataracts? Because the central part of the lens is the most affected, causing a formation of a dense core which is surrounded by a lens-dense epinucleus and a sticky cortex. Most of the hard cataracts, as you see, will have a sticky cortex compared to the loose cortex which is present in the other immature or mature cataracts. The capsule also in hard cataract is very thin and lax and inelastic, and many times they are associated with weak zonules. So the clinical examinations before doing a hard cataract surgery are first is visual acuity, which you do it in any cataract surgery, and slit lamp examination. Cornea has to be clear and there should not be any corneal catheter or corneal haze, and also the type of cataract. The anterior chamber should be of the normal depth, intact zonule should be present, and there should be an adequate pupillary dilatation. And also if there are any presence of corneal thickening, do an endothelial cell count by doing a speculum microscopy. So what are the pearls and strategies while managing a hard cataract in manual small incision cataract surgery? A large section is desired with good side pockets. The section should be around 6 to 6.5 millimeters. Capsular staining using dyes to create a contrast between the capsule and the cortex, and a large capsular excess. Limit the capsular excess within 7 millimeters. That's it should be not more than 6.5 millimeters. And careful hydrodissection. Avoid capsular block, which means that when the capsular excess is too small, or when you do a vigorous hydrodissection, the lens can move up and block the anterior chamber, and this can cause a tear in the anterior and posterior capsule, leading to a nucleus drop. Adequate viscoelastics are always needed when doing a hard cataract surgery. Bimanual nucleus prolapse. Careful delivery by using irrigating vectors and sutures if required. So coming to the various surgical modalities, one is the irrigating vectors method, the phaco sandwich, the phaco fracture, bimanual technique, and brown cataract with inadequate pupillary dilatation. We can do a pharmacological mydriasis, which can cause some amount of pupillary dilatation, and other methods are sphincterotomy, keyhole iridectomy, and stretch pupilloplasty using Coughlin hook. So coming to the irrigating vectors method was introduced by Steenert, and the instruments used are 4 mm wide vectors, which should have a gentle superior concavity, and a 5 cc syringe containing balanced salt solution or a linger lactate. So the technique is mainly we need to have use liberal visco to protect the corneal endothelium and also to retro-displace the iris diaphragm, and the superior vectors bridle suture is very crucial in the irrigating vectors method. So the advantages are we're using only a single instrument inside the anterior chamber, so there's less damage to the corneal endothelium. The AC remains formed throughout the procedure, and also the brunt of the nucleus is taken by the walls of the tunnel, sparing the corneal endothelium. So this is the video. Make a frown incision here, about 2 millimeters from the limbus. And make the corneal tunnel groove and the side port, and we inject a dye. Usually we use trypine blue, and the internal lip should be straight and not curved, so otherwise it can cause a wound leak. And this is a rhexis being done. Whenever there is a poor red glow, always use a dye. So the rhexis is finished outside inward, and then comes to the next step is the hydrodissection. And once the nucleus is prolapsed into the anterior chamber, by rotating it clockwise and anti-clockwise, and inject viscoelastics above the nucleus and below the nucleus, and then remove it with an irrigating vector smith. And the side port can be used to aspirate the subincisional cortex. And finally is the placement of the IOL inside the bag. So the potential complications in this procedure are endothelial damage, that is because of the misjudged nuclear size, where the wound size is small and the nucleus is big, inadequate viscoelastics, and improper handling of the vectors. The vectors should have a gentle superior concavity, and also when you come to the superior lip, the vectors has to depress the posterior lip, otherwise you can get a PC rent. And repeated attempts can also again lead to endothelial damage. And trapped nucleus can be because of again improper bridal suture and misjudged nucleus size and improper vectors not having a good concavity and an improper technique. And iris trauma can be because of a premature entry into the cornea, premature fluid injection, vectors below 6 o'clock iris and causing trauma to the iris, and vectors not pressing on the posterior scleral lip. And PC rent can be because of sharp edges of the vectors, forceful extrusion of the nucleus, and any pre-existing zonular dialysis getting enlarged while delivering the nucleus out. Coming to the phaco sandwich method, this was attempted first by Luther Fry. He used a standard lens loop and an iris spatula. So instruments which we normally use can be a solid or irrigating vectors and a Sinskey hook. So this is the video for a phaco sandwich removal brown cataract. Once the tunnel is made, inject liberal viscoelastics, since you're using 2 instruments here, and in a brown cataract place the irrigating vectors, just little more than 3/4 of the nucleus, and then remove it with the help of a Sinskey hook. So again, the potential complications in this can be breakage of the nucleus into 2. So when the nucleus breaks into 2, you align one part of the nucleus vertically and inject viscoelastics, and you can remove it again by a sandwich method or by using a serrated forceps. And inferior iridodialysis and also stripping of the Descemet's membrane, especially when the large nucleus blocks the anterior chamber and you have not used adequate viscoelastics. And this is usually the procedure of choice in a dense mature or a nuclear cataract. So phaco fracture technique. Here this is a manual nuclear fragmentation for removing a large nucleus through a small opening. And this was first introduced by Peter Kansas, and he used a sharpened cyclodialysis spatula. So the various methods described in the literature are bisector method, trisector, phaco solute and fracture, wire loop, and a phaco fracture at the exit. So I will show you the bisector technique which we usually do. So here, this is a moderately hard cataract. Use a cyclodialysis spatula and then break the nucleus into 2, and it can be removed separately. And this is a moderately hard cataract. And here you can see this is the second video. It's slightly a brown and a hard cataract. And after injecting adequate viscoelastics, using a bisector, which is a sharp instrument, the nucleus is again divided vertically into 2. Yes, and one half is removed with the help of a irrigating vectors and the same bisector. So again, inject viscoelastics to align the other segment vertically, and the other segment also can be removed with the help of an irrigating vectors. So since you're using two instruments in this technique, adequate viscoelastics is very important to prevent damage to the corneal endothelium. So the complication, as I said, is damage to the corneal endothelium. And management of a brown cataract with inadequate pupillary dilatation can be done by using pharmacological mydriasis, using intracameral adrenaline, or sphincterotomies or sector iridectomies, bimanual technique, iris retractor hooks, and stretch pupilloplasty using Coughlin's hook. So I'll show you a technique by doing multiple sphincterotomies. So once the tunnel is made, you can do multiple sphincterotomies. And then do the rhexis so that the pupil is wide enough, and you can do at least a 6.5 millimeter rhexis. And after hydrodissection, you can remove the nucleus, can be extracted out. Cortex aspiration and then implanting the IOL. So next is a bimanual technique. So this again after the rhexis. We use a cyclodialysis spatula. Once the superior pole is come out, we can use a cyclodialysis spatula to support the superior pole and a Sinskey hook to rotate the nucleus clockwise and anti-clockwise. You can see two instruments. So the cyclodialysis spatula protects the pupillary margin and also the rhexis margin. And next is a small pupil, the brown cataract, doing a stretch pupilloplasty. So make two side ports, inject dye, and after tunneling, introduce two Sinskey hooks 90-degree apart. And again do it at a diagonally opposite angle. So now the rhexis is done. After injecting the dye, the nucleus is prolapsed by hydrodissection. After injecting adequate viscoelastics, the nucleus can be removed by using an irrigating vectors. Thank you.